Dear Marrowlings, welcome to this session where we'll talk about some of the important psychiatric questions which came in the November 2023. Most of these questions have been recalled. Uh, there is a lot of overlap with other subjects which are there, like pharmacology, pediatrics, medicine, OBG, and those. So, a lot of other questions are also discussed by other faculties. I'll be discussing four specific questions here, which has a lot of relevance to mental health and psychiatry. So, I'm just taking those questions. A pregnant female with bipolar disorder. The problem the person has is bipolar disorder, pregnant female, has come to the clinic in the third trimester. So they're giving you valuable, important points, right? A pregnant female with bipolar disorder in the third trimester. She has had 4 episodes in the past and is stable on lithium 750 mg since 1 year, during which time she has not had any episodes. What is the next step? They've asked. Now, let's dissect this question further to know what should we be looking for. Now, we know bipolar disorder is an illness which is episodic in nature, and here the person has had 4 episodes in the past, which basically means the moment anybody has 3 or more episodes, we know that it is good to give medication as long as possible, especially if they're tolerating well. In this person, the person has had no episodes and is tolerating the medication well, is already in the third trimester. So, what do we do? Should we stop lithium and let her be drug free, or should we increase the dosage of lithium, or should we decrease the dosage of lithium, or shift her to valproate? I'm sure if you have listened to my videos or the pharmacology faculty's videos, you know, technically speaking, you would not want to be giving valproate in this population, right? So valproate, carbamazepine are drugs which we would like to avoid in pregnancy or people who are planning for pregnancy. So why would we even want to switch to that? Again, when they're doing well, why would you want to switch is the question. Now, so that's not the answer. What else is the answer? Stop lithium and be drug free. Please understand one simple dictum, especially in bipolar disorder. If a patient is on bipolar disorder, you should always instruct the patient never to abruptly stop the medicine until unless we are suspecting some toxicity or those. We don't abruptly stop medicine any single time, because if you abruptly stop, it can worsen the bipolar symptoms. It can worsen the bipolar symptoms. So that again is not the right answer. So should we increase the lithium or decrease the lithium? Actually speaking, if you just read through the question, you know the patient is doing well, right? Now, if a patient is doing well, is already in the third trimester, most probably we would not want to change anything. We would just want to keep it status quo and go on. So that's the best answer if that was given, where you're just monitoring the patient or kind of continue the same dose. That's the best answer you would have chosen. But they've not given that. So if they've not given that, should we increase or decrease? So to understand this concept better, let's take first trimester, second trimester, the third trimester. What happens to the serum lithium levels in general? In the first and second trimester, the serum lithium levels starts coming down. That is why maybe we might want to consider increasing. If it is dropping too much, we want to consider increasing. In the third trimester, especially in the peripartum period, in the third trimester, what happens is the chance of increased serum lithium levels are there. So you should monitor and prevent toxicity. And if need be, we want to even reduce the levels, especially in patients who are showing signs of lithium toxicity. Some coarse tremors, slurred speech, or myoclonic jerks are there. Then you're thinking of it. Also, if you use common sense, you would realize, right? Just after the delivery, what happens? So much of fluids from the body is lost, right? So that also can shoot up the lithium levels. That is one of the reasons sometimes it is practiced that just before, when the labor onset happens, they stop using lithium till the labor is done. And after the labor is done, maybe they get a blood level checked and see the levels of lithium and restart it again. So that's the reason why we would not want to increase in this patient. And what would be the best answer here? The best answer would be to decrease lithium dosage, assuming that if the levels are on the higher side, the toxicity could be of higher chances, and we don't want that to happen. It's a question where they could have given better choices to make it easier, but I think still a valid question for us to know about lithium usage. Some of the students would wonder, sir, should we even give lithium in people who are pregnant or becoming pregnant or planning to have pregnancy? So you're right. You're worried about what? The condition you're worried about is Epstein's anomaly, right? Epstein's anomaly, which can happen with lithium usage. But please understand, a lot of scientific study over years have shown that lithium increases the Epstein's anomaly chances very little, and it is not that severe problem compared to the benefit it can give. So if you have to give a mood stabilizer, you can give lithium in patients if they need and if they have been responding well. So ideally no medications have to be given during pregnancy, but if need be, you can consider lithium compared to valproate or carbamazepine, which is much more significantly contraindicated in people who are planning for pregnancy. Getting it? This is the first question. Let's jump to the next question. HEADSSS, HEADS assessment. What is the HEADS assessment? Will be used by an intern in which of the following patient groups is the question which is asked. It's an interesting question. It's till date, none of the psychiatry books or psychiatry faculties have ever spoken about it, because this is a tool which, even as a psychiatrist, I never knew about it till this question was asked. It's basically followed in adolescent mental health or adolescent medical units, basically developed and followed by the pediatricians. Now, HEADS assessment was developed by Dr. Eric Cohen, who was a pediatrician who worked in adolescent mental health significantly. So, this is a tool to assess adolescents' psychosocial well being. You want to know their psychosocial well being along with physical health, you want to know their psychosocial well-being. That's where you can do the heads assessment. What is this heads assessment standing for? Very easy to remember. H stands for home. You assess where do they stay, who all stay with the adolescent, what kind of interaction do they have. You're trying to get a better idea about the person's home. Then E stands for education and employment. What is this? It is basically assessing questions on, okay, where are they studying, which class are they in, what is the academic pressure they're going through, are they attending classes regularly, some basic idea, or if they're doing some part-time work or something like that, you get to understand what kind of employment they are in, what kind of aspirations they have. This will give you a good psychosocial construct of their mental well-being, right? Next, A stands for activities. What do you mean by activities here? We are talking about things like, what do they do in their free time, what kind of hobbies do they have, how much is their social interaction, do they catch up with their friends, what do they do, are they too much online, offline, all those kind of things. Basically their overall activity on a daily basis is assessed in A. D stands for drugs, of course including alcohol, right? Even though majority of the times adolescents might not be using it, but we know that there are people who start off using drugs or substances of different nature at a very young age. So it's good to ask them rather than assume that they are not using. So that would give a better psychosocial assessment of the adolescent. Then, as part of the heads assessment, we have 3S. What are the 3S? First S stands for sexuality. You're trying to understand whether they are sexually active, you're trying to understand their gender orientation, sexual orientation, all those kind of details to understand more about the adolescent. The other S stands for suicide or depression related kind of symptoms, right? Suicidal behaviors or depression related symptoms, because we know adolescent age group are quite vulnerable for the starting of mental illnesses. Then the other S stands for safety. When I'm talking about safety, you're talking about their own safety and safety of the environment in which they are in. Are they in a safe environment? Are they safe enough? Are they having any self-harm behaviors? Are they having access to any of the are they having access to toxic things, toxic substances or gun or those things? So these kind of things come under the psychosocial assessment of the adolescent, which is very easy to do. So even though as a psychiatrist, I had no idea of this heads assessment tool till this question was asked. After I kind of read about it, right? It's a good tool, I realized. And nowadays, whenever I speak to an adolescent, I go through these questions and ask them through the acronym. I ask them about their home, I ask them about their education, employment if need be. I ask them about their activities of daily living, what kind of things they do to kind of keep themselves busy and happy. D stands for drug usage, especially alcohol, nicotine are quite common in these age groups. Even weed usage is quite common. S, sexuality, suicidality, and you look for safety. Are they in a safe place? Or is there an abuse happening at home? These things will give you a better idea of their well-being, and that will also help you to plan what kind of intervention has to be done. That's why this is a very useful assessment tool in outpatient practice. Next question, a very repeated common question is a patient on amitriptyline, which is nothing but one of the classical antidepressant, was found to be unconscious, potentially suspected of TCA toxicity. Which of the following features is less commonly associated with TCA toxicity? So, a very common repeated question you would have read many times. What are the choices which are given? Mydriasis, arrhythmias, confusion, hypothermia. So, what do you think is the answer? Please remember, when you're talking about TCA, right? TCA is one of the most lethal antidepressants we have. One of the most lethal antidepressants we have. Why is TCA more lethal than other antidepressants? One of the reasons is because I call TCA as a dirty drug. Why do you say it a dirty drug? It does not work on one receptor, it works on many receptors. One of the basic action of TCA is increasing serotonin levels and increasing norepinephrine levels. That is so happening with TCA, but it does not keep quiet. If this is done, it has antidepressant effect, but it also does a lot of other things. What does it do? It blocks H1 receptors, it blocks alpha 1 receptors. Understood? Alpha 1 receptors. It also works on the muscarinic receptors. It also works on the muscarinic receptors and blocks the muscarinic receptors. Not only that, it also works on the sodium channel. It also works on the sodium channel. Now, these are the reasons why lithium toxicity, yeah, these are the reasons why TCA toxicity becomes quite lethal. It has such a vast number of action that it can lead to problem. How do these patients present? They can come with unconsciousness, they can come with tachycardia and other things. They can present with tachycardia, they can have arrhythmias, they can have mydriasis, they can have confusion. What they can actually have is not hypothermia, but they will have hyperthermia. They'll have hyperthermia. So the answer here for this question is hypothermia is not seen, whereas hyperthermia is seen in TCA toxicity. One of the important points you should know when you're talking about TCA toxicity is what is the treatment of choice in these patients. One of the important treatments of choice is sodium bicarbonate. Sodium bicarbonate is the treatment of choice in these patients with TCA toxicity. Very standard repeated question. I'm sure all of you know already, but was asked in the INI-CET 2023. Don't forget about it. Remember about the various actions it does. So because of the alpha 1 blockade, there'll be orthostatic hypotension. Because of the muscarinic blockade, it'll have anticholinergic effects. One of the anticholinergic effects is mydriasis, constipation. It can also increase the temperature and lead to hyperthermia. I already mentioned it can cause H1 block. So that leads to sedation, confusion, and those kind of coma and those aspects. So TCA toxicity is something which has been repeated multiple times. Now, one interesting point you should know since we're talking about TCA toxicity is in the ECG, you can identify TCA toxicity most probably by what? You are looking for QRS widening. There is widening of the QRS complex 1. You might see in the AVR electrodes, you will see a very prominent R wave. A very prominent R wave will be there in the AVR electrode in the ECG recording. Also, you can see increased QTC. Increased QTC prolongation can happen. So these could potentially suggest the person is go through some kind of arrhythmias and possibly potentially die if you don't intervene quickly. So getting an ECG done in a patient with TCA toxicity is important. It can help you in diagnosing TCA toxicity as well as looking at risk of cardiac problems and treating it appropriately at the right time. The last question we will take up is this. A very interesting question. If you have listened to the videos, you would have been able to answer this kind of questions. So consider the following statements and you need to say which of these things are true. What is this they are talking about? Pre-contemplation, contemplation, maintenance, and action. Let me tell you what they are talking about, then we'll discuss the question. So, what we are talking about here is called as trans-theoretical model of change. Getting it? Trans-theoretical model of change. This was developed by somebody called as Prochaska and De Clemente. In simple terms, it is also called as stages of change, or also called as stages of motivation. So, what are the different stages as per this? The different stages are PC, DAMAR, DAMR. These are the different stages you should remember. PC, DAMAR. What does it stand for? PC, DAMAR. P stands for pre-contemplation. C stands for contemplation. D stands for decision or planning. In some books, they say it's stage of planning. In some books, they say it's a stage of decision. Then you have action. Then you have maintenance. Then you have the recovery or relapse kind of a stage. Now, this kind of model can be used in many situations, but one of the important situations where it is used is substance use disorders, where you want to know in which stage they are in, but you can apply the same model into anything else, including your preparation for exam. You can ask yourself whether you are in pre-contemplation stage, contemplation stage, decision stage, action, or maintenance stage. So let's understand one step further. To understand one step further, what we need to know is this, right? What is pre-contemplation stage? Pre-contemplation stage is also called a stage of denial. Means what? You are not even willing to accept that there is a challenge or a problem. Like, for example, in some wards, when you're talking to the patient, right? You tell them, see, your heart attack is because of your smoking. So you need to stop smoking. They would say, no big deal. I just smoke 4 cigarettes. It's not a big deal. It's okay. So they don't want to even agree or acknowledge that smoking is a problem. So they are in denial. That is, they are in pre-contemplation stage. What do you mean by contemplation stage? Contemplation stage is a stage of acceptance. You will commonly see these kind of patients in ICU. In ICU, what happens is when you're talking to the patient and say, see, you had a heart attack, it's because of your smoking or because of your alcoholism. They'll say, oh, okay, sir. Thanks. I understand I'm smoking too much. I understand I'm drinking too much. Now, they don't deny it. They at least say, okay, yes, I agree. There is a problem. It's like all of us who say, exams are important. Now, just because you acknowledge that exams are important, there's no guarantee you're going to study, right? That's the stage of contemplation. Then what is the stage of decision or planning? In stage of decision or planning, you are looking at alternatives. You're looking at alternatives and you're kind of looking at various course of action you want to take up. You are looking at what is to be done next and those things. So you in stage of decision and planning, you're looking at alternatives. You're planning, okay, should I go for yoga therapy? Should I go for medicines? Should I meet a psychiatrist? Should I get into a rehabilitation center? Like that, you're looking at. In terms of exam, it's like you're planning your timetable. Okay, I'll do this modules, I'll do like this, I will read from videos, I'll read from live classes, whatever you're planning. That comes under the decision and planning phase. Then is the action phase. In action phase, what we look for is overt changes. Means what? It's just not about telling, it's also about doing. The person actually starts doing things. For example, instead of just telling, I want to lose weight or something, I start going for walks. I start going to the gym regularly. If I'm planning to go to gym, it's different. The moment I start going to the gym and start doing things, when you see overt changes, then it is an action stage. Then what is maintenance stage? Once you go for more than 6 months in action stage, then you are in maintenance stage. It is not that one day, 2 days you study, but you study for more than 6 months regularly for exams, then you are in maintenance stage. If you, of course, get through the exam, you reach the recovery stage. If you're abstinent and not into substance use again, you are in the recovery stage. Just in case you fall back, we call it as relapse. And once relapse happens, again you go from there to these stages and come down. This is what is called as stages of motivation or change. So this circle will keep on happening: pre-contemplation, contemplation, decision, action, maintenance, recovery, or relapse. The circle will keep on happening again and again till we come out of this whole thing. This can be applied mainly in substance use disorder, but we know that this theory can be applied in many other scenarios. Here, applying this to the question, let's see what it means. They've asked this. They've said pre-contemplation. What is pre-contemplation? Stage of denial. So let's read what they've given. A smoker is considering to quit smoking. Now you tell me the answer. It is not pre-contemplation, right? The person is considering to quit smoking. So if he's considering, obviously, what do you think is it? Is it contemplation? Is it pre-contemplation? Obviously, this is a false statement. Why is it a false statement? A person who is considering to quit is at least acknowledging and possibly in the stage of decision or planning, depending on where they are. So definitely they are not in pre-contemplation. The first statement is a false statement. Next statement, again, contemplation. A person starts walking for health benefits. Now the person has started walking. So is he just thinking, or is he actually doing something about it? He is doing something about it. So he is in stage of action, right? He is in stage of action. So this is also a false statement. It should be action statement. It should be an action statement. Now, how about maintenance phase? How about maintenance phase? A person has been abstinent from nicotine for more than a year. This is a true statement, right? I told you, when you say somebody is in maintenance phase, when the action goes on for more than 6 months and continues, then you call it. Here, more than 1 year, so maintenance phase. So that's a true statement. Now, what about the action phase statement here? Fourth one. An obese person says he can't do anything as it runs in family. He says, "Oh, in my family, a lot of them are obese. That's why I'm also obese. Nothing can be done." So it's kind of in being in denial, not willing to take up the onus and those things, right? That is basically pre-contemplation rather than actually action phase. So this also is a false statement. So the only true statement here is the third statement, which is the only true statement we have. So actually speaking, this being a recall question, uh, none of the answers are correct here, because I think maybe when students have recalled in pool, right, we have kind of compiled these questions. We are not able to get the right things, but I hope you understand the concept. Next time when these kind of questions are asked, you should be able to answer. Please remember, pre-contemplation stage is called a stage of denial. Contemplation is a stage of thinking or accepting. Then stage of planning and decision is a person who is not just thinking, they're also planning about it, kind of looking at alternatives and planning the next few steps. When they act on it, when the overt changes happen, it's a stage of action. Then when it goes on for more than 6 months, it is called a stage of kind of maintenance. If they recover, it is recovery. If they relapse, it is called as relapse, and the cycle continues. So with this, we come to the end of this video where we spoke about some of the important psychiatry related questions. There are other overlapping topics which the other faculties will be talking to you about. Thank you very much for your patient listening. Best wishes for your exams which are coming up.